The worst-case scenario for a combat medic in times of conflict is when they have to contend with not one, but multiple casualties. Recently, armed forces traveling in convoys have come under attack in places like Kosovo and the Gulf, with horrific consequences. British combat medics, faced with mass casualties during the Falklands War, worked with a system called triage when deciding who was first priority for treatment. Many medics were under the command of Surgeon Rick Jolly.
The casualties have come in large numbers in 3 separate incidents. And I won't give you any figures, but I'm proud to say that thanks to the combined efforts of the naval surgeons and the army surgeons and the Royal Marines that support them, everyone that's come in here alive, despite their horrible wounds, has gone out alive.
21 years on from the Falklands conflict, we've asked Surgeon Rick Jolly to explain the actions of an SAS patrol medic when faced with a multiple casualty scenario. We have simulated an incident in which a vehicle patrol is hit by a rocket-propelled grenade. This is a nightmare scenario for an SAS medic who needs to treat the casualties and keep them alive during what is medically known as the golden hour of survival.
Here we've got an individual. He hasn't got time for emotion. He has to apply the principles of triage or sorting very bravely. We divide the casualties into priorities for treatment.
On his first assessment, the medic has to make a series of instant decisions in diagnosing who to treat first. This is based on the history of the incident and the casualty's ability to breathe, not on who calls out the loudest in pain. In medical terms, this is called ABC, maintaining airways, breathing, and circulation. The first diagnosis is the most crucial. Any mistakes or indecision at this stage could mean death for one or more of the casualties.
In his first quick walk around and assessment, he has put an airway into the driver's mouth to keep the tongue forward. Now, the first thing he's got to do is, in suspecting that there might be a chest injury, is to expose the access area. And he goes to his magic bag. Now, I want you to notice how the material from the bag is organized in his mind, and he goes straight to it. He's got a syringe, a needle, a cannula in his hands. And paramedics in the military, especially those who work with special forces, are taught to access the circulation via the jugular vein.
This casualty will still have further breathing problems, but with 3 more casualties to treat, he needs to move on.
This chap in the back of the vehicle, who, from his appearance, has obviously sustained thermal burns, flash burns to the face, to the inside of the nose, the inside of the mouth, and down to the soft tissues of the throat. The tissues of the voice box are very, very sensitive to this kind of heat and can swell up with enormous rapidity. And so he's going to do something about it. And he puts an intravenous infusion up. And the first thing he does, once that is flowing and running and he's got the line stabilized, is he then draws up a dose of steroids to try and reduce the amount of swelling that will result from flash burns of the throat. He's done what's necessary for this patient, and he can put up a little flip card in the back of his mind. I may still have some problems with the airway on this one.
Oh, what about me? Oh.
This chap's going to need help, but he can wait. And he comes down to the prone casualty who's lying there in a pretty well near unconscious state. He sees the warning sign of blood in the ear. He might very well have suffered a serious spinal injury. So very correctly and very swiftly, he gets out the cervical collar. He quickly locks it into an estimated correct position in relation to the body. Then our poor chap will be left. Here he really is the lowest item on the totem pole.
The SAS medic has completed his first round of treatment on all 4 casualties. Casualty 1 has been given an intravenous access for drugs and blood. Casualty 2 has been given an intravenous drip to reduce the amount of swelling in his throat. Casualty 3 has received a neck brace. Casualty 4 has been given no treatment so far. We return to the scene of our Land Rover multiple casualty scenario, in which an SAS medic is halfway through dealing with the injured. He's entered the final part of the golden hour of survival and now has to reassess the priorities for treatment.
Back to the driver, whose pattern of breathing has changed. The lung has collapsed, air is going in to the chest wall. He's got to get a device and a drain valve through the chest wall to drain it. And he quickly assembles the components. It's a drainage tube and an intercostal drain itself. He gets out the scalpel, incises the skin, and he makes the hole wider using the steel pair of forceps. He takes the cannula and passes it along the line of his finger and then pushes until it enters the chest. And he knows that he has struck gold when there is a loud as the air rushes out and he's performed a life-saving procedure. So having left the driver, Pete comes round to the back of the Land Rover again, assesses the patient and realises that there is respiratory obstruction. Probably because the vocal cords have swollen up so much and have obstructed the airway. He has to go beneath the obstruction, below the vocal cords. And to do that, he is carrying a mini tracheostomy set. He then secures this device with a piece of tape which he ties into place. And then, because the patient is suffering quite a lot of discomfort and pain, gets out an ampoule of a proprietary pain relief, draws it up in a syringe, and then without a needle, he inserts the drug straight into the circulation. He needs to establish an airway. He goes to his kit and gets out a nasal tube. He'll have a range of sizes. Quite a good yardstick, if you like, is the size of the little finger. Again, the airway of the A of ABC is being protected. Then, our poor chap with the leg, he'll get out a field dressing, and this is put straight onto the fracture to suppress bleeding and to cover it, to prevent soiling and infection. After the wound has been dressed and tied down, the rest of the bandage is used to tie the leg to the other leg in a form of external splinting. He has done the right thing at the right time. Last for this individual. I mean, when you think about it, if he came into casualty with the leg looking like that, he would be descended on. Now the concern comes for evacuation. So what we've seen here is excellent battlefield first aid on individuals who had been granted this golden hour of survival with life-threatening injuries which could so easily have killed them if they'd been ignored or just abandoned on the battlefield.